I'm pleased now to introduce our general session for this afternoon, Navigating the Payer Landscape. Please join me in welcoming Jeannie Parker Martin from the Corridor Group and her panel to the stage.
Well, I'm very sorry to say that we have no foxes on our panel today. So that means we've got 3 owls, and I think we have 2 dolphins. So, but we're very organized for all those beavers out there. So welcome, everyone. We're really excited to have you here this afternoon. This is going to be a great panel. We have just an excellent group of speakers who are very, very knowledgeable about the payer landscape. So we're very excited to have them. I think all morning, each of you have heard about all the changes in healthcare delivery and an increased focus on patient care, care delivery, the continuum of care, and changes in the payer environment. This morning's panel, the opening general session, I thought was just excellent, with the 3 Bills and Aaron and Mark and Dee and Adam facilitating. And it was a perfect lead-in to our session this afternoon. You've heard about ACOs, ACA, population health, global caps, and everything else that's going on in the payer environment. And we think that this is vital to where home care should be positioning for the future. I want to just underscore a couple of points that were made throughout the day, and some of you may have read the white paper that was sent out previous to the Home Care 100 opening. First, managed care growth has exceeded all expectations as Medicare Advantage rolls have increased and the states have adopted Medicaid plans and managed care plans. It's very, very important. So regardless of whether or not you're in a community or a state, as was mentioned this morning, that hasn't been an early adopter for managed care, you need to position your own organization because it is coming. And some of the states are moving quite quickly in changing their payer environment. Secondly, you heard this morning a little bit about value-based payments and the movement from fee-for-service to fee-for-value. And so we're going to hit on some of those points as well. And then finally, I just want to comment about the consolidations. I think everyone was very gracious this morning in talking about what's happening with independent providers and how independent providers have the opportunity to align with other providers going forward. And this also is very important because as a freestanding provider, you may not have had the capacity yet for one reason or another to align with a payer or in a managed care contract or in a bundled payment contract. So with that, I want to welcome all of our speakers who are going to introduce themselves, but we have just a stellar group. I'm Jeannie Parker Martin. I'm the Vice Chairman of the Corridor Group, which is a healthcare consulting and revenue cycle management company. And why don't we start with you?
Sure, thanks. I'm Dr. Susan Nedza. I am an emergency physician and a clinical informaticist. Come to the panel with some experience working at Medicare, helping define the value-based purchasing methodology, a little tenure at the AMA, and also in the private payer world. So I'm pleased to be part of the panel.
Great. Chris, do you want to go?
Sure. I'm Chris DeRosa. I'm the Western Regional President for Cigna. I have been there 23 years as of this morning. So thank you very much.
Congratulations.
I could think of no better way to spend it than being here with you all today. So thank you. And I would think a couple messages as we get in through is just one, the payers segment, particularly the commercial carriers, are in flux. The things we have done before are not what we are doing going forward. It's really not. And we're really going to be in transition, and a lot of our strategies have gotten quite divergent, and I'll be talking about those as we go through today.
Hi, everybody. I'm Sue Birch, and I used to run a very small VNA in rural frontier Colorado. and I currently serve as Colorado's largest public payer. I run the state's Medicaid program. We cover almost 23% of the state's population, and we have a very interesting perspective. I also come to you today, too, as kind of a ex officio of our state exchange, and so we'll talk about the implications of what those exchanges mean to all of you as well. So have a pretty extensive history in your world from before, and now serve in that public governmental role.
Great. And Marguerite?
Good afternoon, everyone. My name is Marguerite Salazar, and today I sit here as the Insurance Commissioner for the state of Colorado. Prior to coming here, I was the Region 8 Director for HHS. I was headquartered out of Denver, so I got to be a big part of the initial rollout of the ACA. Prior to that, I spent 25 years setting up primary care clinics throughout rural and frontier Colorado, but I also had a contract to do long-term care alternative placements way back when. It was a private business that I had, so it's really great to be here with you today. I think the perspective from where I sit today is that we have never seen such a great disruption in the marketplace as we are seeing today. And disruption, I think, in a good way, because what we're seeing is a massive changeover from how not only private carriers and public, but the whole realm of Medicare, how things are changing there, and how everybody is having to get set up to accept those changes and be a part of it.
Great, thanks, Marguerite. And I just want to let the audience know that we're going to be accepting questions throughout the entire session this afternoon. So we have about an hour. You should text your questions if you have your phones with you. And I think there are going to be instructions on the screen as to how to do that. If you can't figure it out, just raise your hand and we'll call on you. But please try to text your questions. So, Marguerite, I'm going to go back to you just for a moment, if you will. Could you talk a little bit about not just your perspective on the payer landscape, but a few nuances between the federal and state exchanges, the federal and state marketplace? What's it really look like today?
One of the things I think is important to talk about is the fact that we're seeing changes that in the past may not have taken. We talk about super glue versus memory foam, but this time I think it really is super glue. We're seeing, when I worked at the HHS and I was overseeing some of the Medicare changes, one of the big things you might remember was the Medicare fraud, abuse, and waste efforts that were taking place. And people who had been at CMS for a long time told me, we've seen this so many times. Every time there's a new administration, they go out and they try to stop the bad guys from stealing Medicare money. But what they would see is that they'd go out tuna fishing and they would catch a bunch of dolphins. So they would stop and they'd say, okay, we're not going to do that anymore. This time what Medicare has done is set up a whole system to be able to, they call it a command center, in fact, and they can look and see what kind of algorithms are out there in terms of how people are billing and whether a physical therapist or an occupational therapist is billing for 100 visits in a day can really raise some ire. And so part of the ACA is that where before everybody had to be paid within a certain amount of time, the whole rule now is that they can put a hold on those payments, much like your credit card company will stop payments on phony charges that come through. They can do that with certain providers or would-be providers and then go back and check and make sure that they're bona fide. Because of that, we're seeing huge savings, and it's not I think people were really nervous initially saying, well, there's $600 billion going to be cut out of Medicare. Primarily, it was that kind of thing. And we're seeing it's continuing, it's not going away. And that's what we're seeing, again, with the way payments are being made to Medicare providers. Many of you may have seen the announcement that Secretary Burwell made last week. It was a week ago on Monday. And her whole title was about bigger, better, and healthier. And the notion there is how she plans to change the way traditional Medicare is being paid. And again, my message to you is this really is happening. When we look back at 2011, very, very few payments were being made in the alternative funding manner, with ACAs or bundled payments, ACOs, and bundled payments. Today, 20% of all payments that are being sent out by Medicare are through that kind of mechanism. So what she said last week was that by 2016, 30% of all payments made through Medicare are going to be through this alternative funding mechanism. By 2016, it's going to be 50%. So we've never seen the administration make those and set those kind of goals. And I think that home health and hospice has a lot of role to play within changing that payer landscape. I think that home health and hospice is going to be a big piece of helping hospitals in the issues that they have with readmissions. And so I think for people sitting in the room, this is really exciting news.
Boy, that's unbelievable, isn't it? Gosh, Sue, do you have any comments?
I think that in addition to the announcement from the Secretary last week, there were two other really major news releases for those of us that follow health policy. One was the release of Blue Cross data that showed price variation across the country for certain procedures. It was based on bundles, you know, and you could look in any market, and this was transparency data. In addition, there was a letter from MedPAC, who we were talking about a little bit earlier. Everyone has mixed emotions about MedPAC. And MedPAC was saying to CMS, enough with the quality measures. Hard for me, because I came out of the quality side. You know, there's the cost side, the quality side. And we've developed this significant infrastructure to measure quality. But MedPAC's instructions to CMS were basically enough. The burden has gone up. Let's begin to look at those things that matter the most and are the easiest to measure. Things like readmission rates, emergency department visits, hospital-acquired infections, all the things that our panel this morning spoke about and we also heard about in the breakout sessions. And it's going to be critical for us to, while we're still reporting all these other things and complying with regulations and talking about outcomes, to focus on understanding that we've had a convergence now. We've got a convergence between quality and cost. And these new models of value-based payment, whether they be at a local level, a private payer level, the Medicare or Medicaid program, are for the first time, at least in my recognition as a physician, aligned. And I think many of us have been hoping and looking forward to that day, but we also recognize the fact that it is going to create a great deal of disruption in many, many markets. As the president said, would he have liked to have done it some other way? The answer is yes. But I think we all have a responsibility to take advantage of the situation and to participate in what I like to call disruptive collaboration, putting ourselves, no matter which industry we're in, which sector we're in, together, using the data that's now becoming available to really define healthcare locally again, which I think is the exciting part.
So, Chris, I'd be really interested to hear, you know, it's very interesting, you know, as we move to bundling, the provider and payer landscape is really merging together. How are you dealing with that at Cigna, and what's your perspective?
Yeah, so for Cigna, and I think the industry in general, bundling payments is working that way, absolutely working to improve performance and quality, and you'll see a lot of it through really the ACO movement is what you're seeing, is what's changing that landscape. And so we're really looking for more integrated clinical delivery and more even from a digital standpoint, so that we're really closing that loop to capture as much as we can about the individuals and make sure that they're getting the right care at the right time, and we're really improving the quality with it. But as we align those incentives, as I was saying earlier, what changes is really the role of a health plan. So if we have really aligned incentive with a delivery system, there's a lot of things I don't do. It becomes case management, a lot of the disease management and things we do aggressively as a health plan today. In an aligned incentive system, we don't do it. We delegate it, we allow it to be done at a local clinical level because the aligned incentives keep us from having to, you know, keep us in the same frame as with everyone. So there is seeing a lot of change that way, and it's not all at once and it's not everywhere, but you can definitely see the pockets of it as it's beginning to move. And I really think it's hitting a tipping point to become more of the standard than not. We have over 100 ACOs already nationally, and at this point, and that continues to climb at a much rapid pace than it had before. So really, the integration is definitely the next phase for us.
So we have a group of, you know, home care, hospice, personal care providers in the audience. What are some of the expectations then from a payer standpoint in terms of what they should be doing right now to work, say, with the Cigna?
Sure. So I would say heretofore our relationship would probably be one of a contracted relationship directly, depending on whether you're in California or not. I'll leave California aside for a moment since it's always so excitingly unique. But in most other places, we'd have a direct contract. What we really want, and most people would show up and say, hey, we'd like to do something a little different with you, which really evolved around, hey, can we cut a better unit deal in exchange for steerage to our organization? That is really not something we're looking for on a go-forward basis. The real way to show up is we now have talked to our local delivery system, physicians, hospitals, that ecosystem, and we have an integrated way in which we can improve the health and well-being of your customers, because you become a great place once we have those aligned incentives to reduce admissions, much better in a non-inpatient setting for us, or even outpatient, continue to move people back to their homes. But the incentives have to be in place so that everybody benefits from that, or everybody loses in that, so that we have a very aligned incentives. We cannot continue to have one player win and at the other's expense in the entire ecosystem, and that is something we're definitely looking to change.
So I think it's still interesting. So would you expect, if you had like 2 or 3 years out, that a provider in the audience here would be coming directly to you to contract still, or do you think the landscape's going to change in that regard? They'll be contracting with someone else, some other payer-provider relationship?
I think it is, I will use the word, it is lumpy across the country, even in my region in the West. So think New Mexico to Montana and West, it's very lumpy. Some places are far more integrated and they come as a coordinated conversation around it, and others, it's pieces and parts, and there's a little bit of that contracting. But even in a fee-for-service arrangement, we're looking to introduce performance metrics that will help improve it, so we would pay under the market. And as performance came, we would begin to pay above the market, at or above it, depending as you go forward. So it could be any one of those, but outwards, the out years from there, and I'll leave that, I'm really bad at forecasting and projections, right? But so, but out there, it is going to be almost completely on an integrated basis. The idea of a standalone, independent, single contract is really not the way of the future for us.
So Sue, I'm really interested, because Sue sat in your chair, and now she's in the state side. So I'd be interested, what are your perspectives and how do you see this provider-payer landscape changing?
So, you know, people think, oh, Colorado's so unique. And we absolutely are, very advanced on some things. Like everybody knows our recreational marijuana history recently. So, yeah, there are times I think we are a little out there. But
we have a joint right here.
But
Aaron brought those this morning. Oh, that's why we're all so happy.
We can never present on any national stadium or a national podium without bringing up recreational marijuana. But no, seriously now, back to healthcare reform. I will tell you that I do think Colorado has been in a unique position, and I know Health Affairs will be really showcasing 5 states where government has led into healthcare reform. And I think what everybody is suggesting, and certainly what Colorado knows, is that we were a very unique state in that we began expansion and began finding people and getting them covered well before healthcare reform began. And we created accountable care frameworks. And it's our version. We call ours ACCs, Accountable Care Collaboratives. But these are really Medicaid and Medicare in an ACO framework. And so I think you will continue to see major movement from both Medicaid and with the announcement last week of Medicare coming on board. The other thing that's happening in Colorado, and so these frameworks, they're regional care entities, and we pay a managed fee for service, and we absolutely have performance incentives. We are negotiating with our federal partners right now, shared savings deals, and we are looking to drive a community health per member per month. So in addition to this evolving way of kind of paying differently and moving towards either subcapitation or capitation, we are absolutely interested in bundling in all of our community providers, and there's no reason that home care couldn't be a significant leader. Now you might be saying, yeah, my state's slow on Medicaid, or that's not going to happen in my state. But let me tell you, in Colorado, even my good friends, the private payers, last week committed to a parallel payer collaborative to begin to align our work so that we are all paying in the same way. And it's really exciting. The other piece that's dramatically different right now is our federal partners are begging the states. They are begging the states for innovations. And so we are launching our State Innovation Model Grant, which is a $90 million effort around bringing in behavioral health. And so again, working with home care and the community providers, we're integrating physical and mental health services. And so you're going to see this enormous maturation, if you will, of how we continue to do both post-acute and pre-services in a whole different way. And I just tell you that because I think the alignment between public and private has never been this significant, and I don't think there's any going back. And I have talked with many of you on the breaks of, yeah, this stuff's gonna, just the pendulum's gonna swing. There's no more money. It's how we use this money differently. It's how we work together. It's how we align public and private and drive efficiencies. So I'll just stop there and tell you that it's very exciting, and we want entities to come forward and say, I've got an idea about emergency room reductions or readmissions. We are absolutely paying for key performance indicators of that nature in our framework, and I think there's no going back from this new kind of rationalization of the system.
So let me ask a clarifying question. There are a lot of hospice providers, probably 50% of the audience has hospice, provides hospice. When you say home care, are you including hospice or are you saying home health or something else? I think it's a really important conversation, particularly as we talk about bundling and how does this merge in? Because the Medicare Advantage plans may carve back in Medicare, the hospice Medicare benefit. So if that occurs, and I think we talked about this previously, if that really occurs, then you're talking about a bundled payment that's going to impact the entire spectrum of care delivery. So how are you defining?
So in Colorado, we have all sorts of daily negotiations with our federal partners. We are taking a life stage approach. I think to continue this siloed, fragmented nature is really a mistake. I think we have to look at the life stage approach. I think we've had several speakers allude to kind of really delivering on a system of health versus a system of disease burden. And I think if you look at the life stage approach, I think personally, home care to me is encompassing of both home health and hospice. And Colorado will continue to look kind of cradle to grave about what we need to do to create not only health bundles, but health and well-being bundles. So we are in discussions with both the CDC and CMS about how we bring those two type of bundles together and begin to continue to mature that payment side of things.
So life stage approach, that's like a new term. I haven't heard that before. Well, so it's like something new we have to think about.
Absolutely, because when you think about maternal child events and that being,
it's great.
We pay in Colorado for 40% of all babies being born, and that's a low number nationally. I know my friends in the Southeast, it's more like 50 to 60% of all births. So what an amazing place for home care to be involved in maternal child efforts. But then we also look at the burden of chronic diseases, then we look at frail elderly, and then we look at kind of the palliative and hospice realm.
So any other comments from any of you? Yeah, go ahead.
Yeah, I've got one. You know, as Sue talks about the crossover, what I'm seeing a lot with national insurance companies coming in to file rates, they're talking about the bundled payment approach and telling me about how they've got to go after whole segments of different regions that they're in. But we just recently did a network adequacy study and did a whole piece on home health and hospice so that as we hold them accountable for having adequate networks to serve the people that are buying the product. We're including home health and hospice, and then they are in turn using those costs to create their rates that they're then filing with us. But I'm seeing, these are usually the national companies starting first. So it's not just going to be Colorado, but it's going to be used across the country.
Coming out of the Blue Cross system, there are certain plans that have embraced hospice. And one most recently is Cambia, if anybody's from the Pacific Northwest, where their CEO has actually spoken about the need to begin to talk about these things. It's very difficult, we know, based on what happened during the accountable care debate about death panels and such things. And it's made, and I'll be excited to hear what Chris has to say about it, but it's made it very difficult for the private payers to embrace moving people, what we would call steerage, from an acute care, continued model of expending those type of resources into either palliative or hospice care. I'd really encourage all of you to think about what your role is in palliation as well. One of the, I think, struggles we're all having around definitions is the majority of people, when they think about hospice, they're really thinking about that end-of-life experience. And if anyone's read, has anybody read Being Mortal by Atul Gawande?
Yeah.
It's the best book I received as a gift this holiday season. I don't know what that means when my family's sending me books that tell me about thinking I'm mortal. But aside from that, it really does. It's all about you. It's all about that change in the life steps. And we need to be able to help, you all need to define where you fit in that continuum of life, not the continuum of care, so that your position when these changes occur in such a way that the private payers can embrace it will serve you all as serve the people in our communities. Because there still continues to be a problem embracing hospice on the payer level. And some of it is based on just past experience. So really encourage you all to think about how you might want to reposition yourselves.
So we have two audience questions that I think are, apropos. One of them to this, not to the hospice discussion, but to our prior discussion. So it says, in our area, we're seeing some commercial and Medicare Advantage plans introducing CMS-like 5-star programs to pare down providers. And I know a comment this morning was made about Colorado from Aaron Denholm, that the network was narrowed to 5 providers. So what would you comment? Are you introducing 5-star-like programs? And if so, how does that impact home health and hospice providers? So let's start with you, Chris.
Sure. No.
Okay, that's easy.
We're not. I mean, but we're not so much for the 5-star that we've gone in 2 different routes. One, in our programs, we keep our network whole, and we incentivize our customers around the more efficient and the higher quality physicians, but not excluding the entire network, because we really want around choice around for our customers. Have we begun to have some other narrower networks? We have, and it's been more around our collaborative care, or our ACOs, and having those as a complete network, because it keeps people at the like incentives and the qualities there, but not offered on an exclusive basis. Again, I think it's kind of lumpy right now, and the market's in transition, so it's very tough to really have a whole marketplace in one area. That said, and I'll speak on behalf of the industry for a second, and I won't name names, although it's so tempting, right? But there are a number of bad things being done in the name of narrow networks and ACOs. If it's truly purely driven on a unit cost, and we simply just want a low-cost basis to drive that out there, then yeah, there are a few of those, and it is not a pleasant situation, and it's not, I think we're right to think about network adequacy and making sure we've got the right providers and the right quality of providers in place. But it's not everywhere, and it's not ubiquitous. What I was saying earlier is the carriers are definitely heading in different directions on it, and it depends on the direction they're headed and why you are doing it, as much as what it is you're actually doing.
So Sue, do you think at the state level you'll be introducing 5-star programs or anything similar to that?
Well, this is, to me, kind of where we've come in this whole transformation process, because I would have said, yes, we are going to be more quality oriented, and we already are paying for performance incentive bonuses to our high-star performers. So those that do better on readmissions or high-cost imaging, those that drive these trends in the right direction, get better payments. And we hope over time that our federal partners will allow us to do a bit of shaping of the networks, because we can't afford to have the variation, pay for the variation and the variation in quality. We don't have it in place yet, but we are working with NQF on population health metrics. So it'll be interesting to see how both, again, the private and the public side come forward with a bit of the network challenges, but I think we've got to look at how you bring consistency and standardization throughout. So it's a very exciting time. We do not have permission right now, but we are in discussions about when can we start narrowing.
Oh, interesting. Yeah, go ahead, Mark.
Jeannie, I think one of the big issues we have is standardization of what does 5 stars mean. And I got a lot of complaints over the last year about some plans who cut certain doctors out in the middle of the plan year. And so consumers were forced to go out and find another physician. And when we really started looking closely at why were certain providers axed, there really wasn't a good reason. And so what I'm saying is you can't do it in the future in the middle of a plan year. And and I understand that they're telling me, well, with the medical loss ratio, we only have 20 cents of every dollar that we can really play with, in a sense. So we've got to do everything we can, and that's why we're seeing more narrow networks, the EPOs, those kind of things. But at the same time, there's got to be some consistency and something that people can rely on, because as you know, it's real hard for a beneficiary to have a doctor they rely on and then have that doctor kind of pulled out from under them. So we're doing everything we can to provide some kind of standardization.
Okay, so I'm going to go to a second audience question about volume. I think this is really an important question, particularly as it relates home health and hospice providers, and home health somewhat in particular, because that shift to value-based fees versus volume-based fees is really a difficult challenge. We've got some really large providers who've been driving volume for decades. So what are some of the incentives that these high-volume providers, and the question was really about orthopedic surgeons specializing in total knees and hips, but I think we can twist that question to what incentive does a high-volume home health provider have to shift to bundling, or to even want to request bundled payments? So who'd like to take that?
Well, I'll start by saying that we certainly know, again, in the risk stack that we're going to have to stratify. Again, Colorado's clearly in a managed fee-for-service arrangement. We have our first global demonstration going off in the western part of our state, so we have approval. We have 2 others kind of in the oven baking. But your example, about joints, we think that there could be significant upside for our really high-quality folks that could handle kind of better outcomes, and we think that we are progressing so that we've got the data analytics and the infrastructure in place to be able to allow for some of that, because we also know in our regional care framework that we've got population health metrics that will align with that. So we also think that many of those players that participate will also be interested in some of the preventative population health work that has to happen. And so I think they are starting to see it as a new ecosystem as well, and a way for them to be involved in greater health provision, not just traditional kind of home health functionality and rehab work, but also kind of in taking a kind of a lead market role in healthy neighborhoods, health homes, and whatnot.
And that came across very clearly this morning, just this sort of transition to a new environment. Yeah, Chris.
Yeah, so I would say one word to start, and that would be customers. Our customers, we have many more of them now in high deductible programs, and they very much see the transparency on the cost for it. Our customers are not interested in high volume. Our customers are in, my knee is done and it's better and I don't have to go back and it's not an ongoing problem for me, both financially and in the quality of my life. And as we begin to present more and more through transparency in our data tools to our customers, here are your choices in your area. Here's the ones outside of your area we'll pay for you to go to. Here are the quality results on them, and here they go. The customer will begin to transform volume to value all on their own. Customers are way more engaged than they were, 10 years ago, 15 years ago, $5 copays. They didn't have one iota. I will tell you, they know now. They ask us. We get a lot of calls. Our calls are not about this, that, it's really about information and people searching to understand both the quality and value. Is it perfect yet? Sure isn't. But it's getting much better, much faster, and I would say on an exponential versus a linear curve is where it's getting to, and that's what's going to change it.
Any other? Susan?
Yeah, I think the volume's a two-edged sword. We all know that you can drive a lot of efficiencies. Certainly in your investment in infrastructure, for instance, we are all touching upon data and the need for data. The ability to leverage data and have that kind of infrastructure available is certainly something that comes with volume. Standardization does as well. And so if you are looking at it from the terms of being a high volume provider, those are the two benefits that I see. You get to a point though when we begin to talk about the customer or a specific market where you need to differentiate yourself on something other than volume, and it might be patient outcomes or some other item, that volume no longer becomes the important driver. One of the more erudite people who I've had the privilege of working with, Don Berwick, said when we get to a point where we start talking about cost efficiency, we need to recognize the fact that efficiency in and of itself, being able to do a lot in a very efficient manner isn't going to get us all the way where we need to be. So I wouldn't assume that volume in and of itself is going to be the valuable driver it's been. It's certainly helped us all in spite of BBA. Where there were cuts, we were able to make it up in volume. And there are providers, be they hospital, physician, all across the country that are trying to make it up on volume. But as we're now being asked to do more for the same amount of money or money at risk for more people, that begs the idea for care reform. It's the coordination piece where we're going to drive our value. So I would argue that volume will still in some markets be valuable, will get you what you need, but it is a very short-term strategy because you're going to need to provide your service differently. And again, back to that idea of disruptive collaborations with new partners.
Mm-hmm. So Susan, you mentioned care coordination. I'd be interested in any of your perspectives on the role of home health and hospice providers in care coordination, and are other organizations going to be utilized to maybe manage or serve as a go-between between the payers and maybe more upstream providers?
Yeah, I think home health, you guys are in a great position. You're in people's homes. You see where they're at. You have a much greater touch with them on a regular basis. And that's why those that have a connection to the digital records and the clinical loop are going to be the ones that bring a huge greater value. The ability to extend the delivery system that completely, it really is the frontier, and it's the right place to be, particularly as we start talking about true healthcare not in terms of the absence of disease, but in terms of actually being healthy. You're in a great position, closest to the customer, and in a very intimate kind of way. I think it's a terrific place to be to help engage that integrated model, if that's the path to take. If it's a high volume other play, as we were talking earlier, then that will work for the short term, but not for the long term. It really is about the shift that's taking place. And it'll be tough to see for some, depending on the market. It may work for a while longer.
Mm-hmm. I think the greatest threat is when a health system, and this is going on in my own market in Chicago, develops these teams now that are doing the home visits, where they're sending their care coordinating nurses, navigators, and others into the home setting, and trying to substitute that for the services that you provide. And some of that's based on a lack of knowledge. As a physician, an emergency physician, I never was connected to a home health agency. I took care of patients that came in from SNFs, long-term care, all of those entities, and I would call the SNF or I would call the LTAC, but I didn't know who to call from home health to get the story. My story started and ended with the ambulance, the people in the EMS system. So this connectivity into the acute care system, the pre-admission, not just the readmission, but the pre-admission relationship is going to be really critical to maintain and allow the system to take advantage of all of your breadth of activities and talents so that you're not displaced.
So, go ahead, Sue.
Well, I have to say, as a nurse, to me, it'll be a travesty if nursing doesn't step stronger into this role, or home care. And really, when you think about it, hospice really has owned this space with team-based care and really their principles of teaming. So I think there's so much to learn there, but I will tell you, as I sit and visit with my peers and other secretaries around the country, you have extraordinary examples of, for example, in New York, the NORCs, the naturally occurring retirement communities, and housing case managers being sometimes the leaders. In Colorado, we have some extraordinary partners with our behavioral health partners, and they being the strong case managers. In other areas, it's home care. So I have to say that, all health is local at some point, and I don't think we're ever going to get that variation or the lumpiness out of the system. So I do think it's really important that we play to the region's strengths and allow for some of that kind of unique tailoring. But I think the bigger issue for me is how we can drive kind of a case management reimbursement, because I do think it's really important in our evolving payment arenas, either, by the time we get to what truly is the kind of global cap rate for Colorado, it's really important that we acknowledge the magnitude of that case management role and make sure we build it in.
So this kind of plays into one of the audience questions. So, I have a great care coordination model. I have a great specialty service. Who do I go to talk to? Who do I go to at Cigna? What's the right person to go to talk to to get the contract for this specialty service or for my care coordination program? Chris?
Yeah, I think for us, you can call us, and I think what we've been doing in a lot of markets is really convening the right players. It's not necessarily us all by ourselves, but it's really thinking about who those natural partners are. As you think about patient attribution and patient alignment, is how do we find those partners and sit down and really talk through that integration. It is different in a lot of areas, to your point, it is lumpy. We have 100 different ACOs today, or collaborative cares, and while they're generally bucketed, they're different, and because we do have to adapt on each one of them, and we're experimenting as an industry and as a company, and so a lot of people are showing up with different ideas. I'm like, well, as long as it can prevent, like, yeah, why not? We'll try it on those areas to see what's going to work for us. We're nothing if not pragmatic, and so we are trying to find ways to make that work.
So, Chris, are you saying at Cigna they call you, or who?
You can call us.
Not just us, but
well,
who?
normally we call our local medical director. It's really running through our clinical operations, not our contracting team is where we're running those areas. While the contracting teams are involved, it's really our clinicians that are laying down the track for our collaborative cares. You could call me or send me an email if you want. It's christopher.derosa@cigna.com, and I'd be more than happy to engage in it. But it definitely, and or your local delivery system that is engaged with us already. Again, it's your partners, because eventually we're going to get to that conversation. It won't be a one-to-one sort of thing.
So I think I heard you say that your medical directors are driving?
Yes.
Those, okay.
Yes.
So medical directors, if you have a relationship with a medical director, that might be an entree into Cigna at least.
Yeah,
do you think
absolutely.
that's the same, Marguerite, with other, at the public level?
I do believe that. You mean with private sector carriers?
Yes.
Exactly. And if people are having trouble reaching out to someone, call your state insurance commissioner, because that office can direct you to the right person. We regulate we don't regulate self-funded plans, but we do regulate all the other carriers. So if you have any questions, just feel free to call the departments, or and we're going to say, look at your contract. And in your contract will be information on who to call and who to talk to.
Mm-hmm. Susan, yeah.
It's great to talk about models. Having been a medical director at a health plan, it was the right place to come to. I'll reinforce that. But you need to know your own numbers. You need to know your readmission rate. You need to know your emergency department visit rate. All of those things that are going to pique our interest are going to be related to those key metrics. How you prevent infections. So when you approach one of the medical directors, be they at a private plan or a public plan, or the chief medical officer at a CMS region, understanding that yes, you can have a wonderful model, but you're going to need to be able to say, and this is the result. So not just clinical not just the clinical outcomes, but the metrics where these plans are being evaluated. It's really important that you come with that information.
Go ahead, Sue.
So in Colorado, as well as, again, some of those other states that have Medicaid ACO frameworks, it's absolutely important to get to your regional ACO framework. And that is where there's kind of an inclusive group, there's leadership groups, there's certainly all sorts of work groups that are going off. And the other thing that I would really encourage you to check out, there are amazing innovations going off through CMMI pretty much in every single state in this country. And so if home care isn't at those tables or aren't on those work groups, if they aren't kind of co-creating as we shift this environment, you all are missing the boat, because you need to be there explaining what you can do and why it is distinctly different. Because I will tell you that in the absence of people being there, there are others, such as more traditional hospital providers, that say we can take that on too and just pay us for that. So I do think it's really important, in this framework of contracting, that people understand there's this new paradigm, and you've got to search it out, and you've got to insert yourself in the equation. Because that's certainly, we've made it easy in Colorado, but I know in other states it's not so easy to kind of find out where the ACO action is or how the framework is playing out.
Chris, I'm going to go back to you. One of the questions that often comes up is about the value proposition that should be brought to the table. You talked a little bit about some of the metrics that you need to bring to the table. Is there any difference in sectors, home health versus hospice versus private duty? When they come to the table, what kind of value proposition is Cigna really looking for from a provider? And maybe be very, very tangible. What is it that I need to bring to you? Maybe it's metrics, but what else do I need to have?
All right, so very specifically, it's going to be around 2 areas, right? So we're going to talk about the integration. Again, how are you integrated into the delivery system, and where those partners are and how established those relationships and pathways are will be critical. The second is going to be around, as I said, closing the loop, both the digital and clinical, closing the loop. How well are you capturing that information in the home when you get the blood pressure, whatever? How is that ending up back into the clinical system with the primary care physicians or the specialists or the others, and how are we really making sure we've got that closed loop to go through it? Some of the standards will be around licensing, making sure you have all the right licensed people in the scopes and those other, but you all know that better than I do, and so I won't even attempt to go down that path. But those kind of basic hygiene things will be important, but it's really around those 2 areas. It's around integration, and it's around the closing of that clinical loop is the real value proposition we're looking for. And then it's around your intimacy and the quality of care you're delivering. So we do look at our patient satisfaction scores very seriously, and they matter quite a bit. For us particularly, a Net Promoter Score, which is a measure of your customer satisfaction, it's actually at the board level. Our board laid down a goal for us, and it is all the way through our management incentive program. So this is that time of year for compensation, so I'm really, really focused on that, right? And a quarter of my bonus is going to be determined on the Net Promoter Score improvement in my region. Turns out I'm focused.
Yeah. Very focused. So, Susan, do you have any comments based on your prior experience? What value would you have been looking for?
I would have been, I think the integration. As a physician, I'd like to know how you're using your medical directors. How many medical directors are here in the audience today? So how have you integrated them into your strategy is a really important question that I would ask, because I would need to go back and have a relationship with someone in your entity. So hospitals would tell me, here's the VPMA, or here's our chief medical officer that you should be communicating with. That would be one place that I would really recommend, that when you go to approach one of the physicians or a leader at one of these, at a private payer or a public payer, or at the insurance commissioner's level, that you do come forth with a physician who's going to be leading the way on and participating within your own organization, because that allows us to build the bond with you. I'm much more likely to take into account someone that, it's my own bias. If you don't bring your medical director, you don't know their name, that's a problem. When
I say integration, there's one follow-up I go on integration, just to be clear and kind of bring it to life. So we have a number of integrated partners we're working with. We don't have medical directors eventually assigned to those delegated groups. They have medical directors. We fund the care coordinators in those areas. So when you start thinking about integration, it cannot just be a coalition of a bunch of sovereign entities together on that. You have to truly integrate, which means there are things you're going to do that you're going to stop doing because another partner is going to do that in the value chain, and things you're going to start doing because another partner is going to stop doing it. If all of you have medical directors, and we have medical directors, then I have taken nothing out of the system from an improvement and an affordability standpoint. So you have to think an awful lot about your sovereignty. When I say integration, I really mean integration. And we're doing it with others. We've given up a number of our arrangements. I no longer have nurses and physicians. They're really being delegated. Now, we have oversight and conversations about it, but it's not something I'm doing on a day-to-day basis. I'm not doing disease management. I'm not doing those other areas because they are, and they're doing it more effectively. And in that partnership, that's the best place to have that service done. So, and even from a claims paying standpoint, we're doing the same kind of thing. So really think about that. It's not just, well, we all showed up together. We have to really be integrated.
Yeah, and this one is a no-brainer to me again for home care, because where do we go? Out into homes and communities. So if you're not knowledgeable about your Medicaid's crosswalk projects, looking at housing alternatives, there is an enormous initiative right now about how we have supportive housing environments that are unlike anything like our traditional ACFs and SNFs. So I think, again, we have to look at those kind of leadership opportunities where we can really get involved in more of the functional and support service type roles. You know, I know in Colorado we have an enormous push towards this creating a culture of health. And so we've got, you know, our seniors and our Silver Sneakers projects woven in. And so if it makes sense to use a home care agency to drive more public health, kind of population health improvement for my Medicaid population, I'm going to award that contract or that, you know, collaborative behavioral health work. Huge depression issues with our elderly populations. And, you know, it's not just kind of that traditional Medicare world. We are a dual state as well, but people have to start thinking differently, not just the chief medical officers getting together. We do have a RICO, or Regional Care Collaborative Medical Officers, but we have a housing initiative. We have a huge workforce initiative because, as Chris says, we are looking at what we need to do to bring up an entire army of kind of community health workers to support this movement against the over-medicalization that's been occurring.
So what's the Crosswalk program?
Medicaid Crosswalk is a program to really understand how you can use Medicaid dollars with housing environments and pay for case managers kind of that are in housing environments.
So there was an audience question. It wasn't about this, but the audience question was, would any of the private or public payers be open to paying home health providers a fee to monitor on a routine basis high-risk patients? So how would you go about that? You're shaking your head, Jess.
We would, and we do. We actually have arrangements where, like I said, I was talking about the disease management, we are taking the dollars that we collect, X dollars PMPM for that was in a rate, and we are funneling that to the delivery system to do that service instead of us doing it. And if we can do it at a more efficient basis, that's something we pass on to our customer and all through the incentive payments to the providers. Like I said, everyone has to win, or so we all have to lose. We cannot have a system that's aligned where we have winners and losers at each other's expense. It just never turns out to be that efficient. So yes, we would pay for that.
And it's not just the monitoring. The monitoring is really important, but if you can do a fall prevention program, I mean, before someone needs a hip replacement, I mean, we just think about frail elderly and the risk of falls. You know, the fact that you are in the home, you can look in the medication. I mean, there's medication reconciliation programs, there's fall prevention. The idea of depression screening is another one, where those are really important services that resonate from a prevention perspective, which is before the admission, if you will. Forget the readmission, I'm pre-admission. And you know, if we understand that falls is really one of those things as a harbinger of a decline for many, many people, that resonates. And I know that I've been involved in some programs where there have been payments, in this case it was to EMS, but could very easily be in home health for those type of screening processes on a community basis.
Mm-hmm. Yeah, Susan.
I will also tell you that I don't think we've been as savvy in the government arena helping this industry understand too that in the emerging role with people with intellectual and developmental disabilities in living longer, huge, enormous potential there, and we absolutely pay a capitation. The behavioral health realm. So there are these populations of folks that we're already, and we're looking for kind of new providers or the right mix of providers taking care of those. And we're also looking at, again, that public health, that culture of health. How do you keep people from worsening conditions? And so we are absolutely in all sorts of conversations and negotiations with the federal partners. And this is not unique to Colorado. Many states are trying to work with CDC, the Center for Disease Control. Again, how we drive per member per month type of reimbursement.
Mm-hmm. Marguerite?
Yeah, one other great opportunity I think comes from what we're seeing as the kind of the failure of long-term care insurance. And every month I get providers coming in to me, carriers saying they need 50, 60, 70, 80% increases in their premiums. And so people can't afford to do that. They've paid a number of years and then they're getting, you know, this kind of an increase, so they're dropping it or they're trying to figure out what they're going to do. And I really believe that home care can play a huge role in helping people stay at home. And as we see the evolvement of different types of insurance, that it is not going to be for nursing homes, but really to try to keep people at home. We see large organizations like AARP and other groups like that saying, let's be creative, let's figure out how to get this silver tsunami in check and try to keep people at home, and that's where you all clearly fall into place.
So we just got a question from the audience that you just mentioned, a falls program. What other kind of programs are payers really interested in? And Susan, I think your role in the Advanced Illness Management AIM program, the specialty service where you were, what other kind of specialty programs do you think payers are looking for now? And then what kind of value proposition do they bring to the table when they come?
Yeah, one of the more interesting ones I saw when I was involved in care transitions was a medication reconciliation program where the groups that were providing home care services also included a pharmacist on the team. And they made a one-time visit, day 2, to the home. Because you're on a set of, especially if you're in managed care, you've got a formulary of medications. You go in the hospital and they change your meds again based on the hospital formulary. You have a hospitalist, quite frequently, who writes your new prescriptions, and then you get home and you have someone who's elderly who paid a lot for their older medicines, and they tend to keep them. And so if you, guilty as charged, I still keep mine. But what happens is when you go into the home, and we always told the paramedics, grab everything you can find and put it in a Tupperware container. It was rather rudimentary medication reconciliation. But it's well known that that 2-day post-hospitalization visit is a critical one. And it's great if someone can get into the doctor, but there are areas of the country where that's not going to be feasible. So I think that's another example of a program where either use telehealth services with a pharmacist or incorporate them into your home health care as a valuable service.
Yeah, I have 2 going on right now that I can think of at the top of my head. One, we have a sleep study program where we're moving sleep studies into the home and out of facilities, and the other is, I'm just blank on it, right? Dialysis. We're moving a lot of home dialysis. We're trying to get people out of having to go into there, and there are many people who could be home dialyzed, and we're really moving on both of those, and I have 2 studies underway on those right now. So those are 2 examples. If you've got good examples, I'm all ears.
Colorado has an amazing spinal cord injury demonstration going on. And we also have a foster care specialty, which enormous expense with foster kids. And it's a very interesting partnering kind of medical and social services arrangement. And we too have a 3rd one that's really exciting, and it just escaped me. So there's all sorts of these innovations that are percolating.
So real opportunities for pediatric providers, to come to the table. So you said, Marguerite, earlier, and I'm interested in everyone's perspective on this, how quickly bundling is coming. You talked about that in your opening remarks. So, realistically, is it really, we talked about this a couple of years ago, and there was a bundling presentation, a workshop just a little while ago. How quickly do you think it's going to really transform the industry? Is it going to be in 2016? Do you think that it will come that quickly? You're obviously doing a lot in Colorado. California probably has some pockets. There are pockets around the country. But if you look at the national perspective, how quickly is it really going to come?
I do believe that the Secretary is serious about, at least for Medicare. And like I said earlier, I'm seeing some of the larger national companies also putting that together. I mean, you've seen that. One of the things, though, they don't want to do it in a vacuum. And when Sue was talking about how to participate, I wanted to mention that the Secretary is going to put together a group. And let's see, it's right here. It's called the Learning and Action Network, Payer Learning and Action Network, that I would highly encourage someone from home care and hospice to be on that group. It's going to convene March of 2015. So, I think being at the table to see what's going on, to be able to form it in ways that works, because you're on the ground, you see the way it ought to be or could be, and because I do believe that it's happening. It's like I said earlier, we already see 20% of Medicare payments are coming forth as bundled or through ACOs, and so it's just gonna continue down that path.
What was the group you mentioned? I don't think I caught
it is called the Healthcare Payment Learning and Action Network.
And who's convening that group?
HHS.
HHS.
Yes.
So the other thing I think this industry needs to wake up about is the Wyden waivers. So the 1332 waivers that are coming up in 2017 allow us, those of us that are really transforming the system, to have kind of the final icing on the cake. So it gives us the final place of saying, hey, waive these rules, let us move in this direction. Oregon with their experiment went out a little differently on their waiver program, but it gives the rest of us that are out front kind of this next level of kind of flexibility for how we want to continue to mature the payment piece. So I absolutely agree with Marguerite. The bundles and payment reforms are happening. The bottleneck, in my opinion, has been with OAC at the federal level, the Office of Actuarial, I can't remember what the C is for, but to get the final approval and blessing from our different actuarial partners has been tricky. It's been a little too slow, but I know the Secretary has really committed to escalating the process. So I think that these shifts in your lead state will really start being ready for review and different evaluation parameters. So stay tuned.
Chris, what do you think? How fast?
Yeah, didn't I just say earlier, like, I don't do forecasting?
That's okay, we're asking.
It's hard, right? Yeah, I know, I do forecasting all the time, right? It's in a number of places now, and again, the markets go. California, I'd say, is going to be there, like, on top of it already for there. I've seen a lot of it in Arizona, and I'm trying to think, and you're right, pockets start popping up in different communities, and it's not so much state by state, it's going to be community by community. We begin to see it in maybe in the Dallas area, or Houston is actually one that's on the cusp. You see it in one area of Florida, but not everywhere in Florida. It's going to come through that way in a very kind of lumpy market by market approach.
One of the more interesting announcements that came out, well, I think it was before the holidays, was that United Healthcare is working with MD Anderson and potential bundles for cancer care. Where the cost is going up within the health plans and in the public sector as well is in cancer care. And my physician colleagues in oncology recently have come out in favor of bundled payments. That is a really important inflection point in the professional community. And the reason they did it was because it was a way to preserve community practice and access. The most recent consolidations in physicians being purchased by health systems in their practices has left entire states with no independent practice. So cardiology, for instance, there are no independent cardiologists left in Wisconsin. They're all affiliated with the system, which is really good, but from a payer perspective, makes it much more difficult to negotiate a non-fee facility rate, right? So what's happened now is you're starting to see those specialties that are still somewhat independent, where they have a large community practice, sponsoring bundles. Orthopedics, certainly. They've been in for a while with the ACE demonstrations. You're seeing it in oncology. And they're actually asking for a carve-out on the drug prices, but they want to be able to do the care coordination. You're going to see bundles most likely in my own field in emergency medicine, which I'm not sure how we're going to do it, but I'm on a task force looking at it. And then the super subspecialties. So we've all wanted to manage diabetes, really tough. But when you start to think about chronic diseases like rheumatoid arthritis with a very high spend associated with them, there's some interest in that area by the rheumatologists as well. So I think you're going to see not only patchwork based on location, but also on which service it is. And certainly any of you that are involved in home infusion, the move to move sleep testing, home infusion for cancer, home infusion for other medications is going to continue to be pretty unrelented. So I would recommend that that's another area where you're going to see it, and you need to know what's going on in your own market.
So we have 3 audience questions that I just want to bring up. One relates to capitation and risk taking. How much are you seeing full capitation with providers right now?
Well, obviously you see it heavily in California. I've got a couple in Arizona, a couple, and I'm trying to think just in my region, and in is probably the biggest ones where I've seen it. I know there's a lot of demand in the other states where we're actually getting a number of providers coming to us requesting capitation. It's a good tool to align incentives, but it has to be judiciously. Anybody who lived in California in the early 1990s would know what a weapon of mass destruction looks like. You have to really make sure that organizations are prepared for capitation, understand what risk is, understand how to reserve against it, and make sure we have enough tripwires laid down so we all understand when things are not going to go appropriately. So there's an awful lot to it. But it's definitely more and more to have a conversation. I haven't had this many conversations about capitation outside of California in a really long time, and it's everywhere. And my peers nationally are having the same conversations in the Northeast and in the Southeast around capitation and risk-based, absolutely.
How about in Colorado?
Well, you know, we are moving carefully on this issue. We have, as I said, our capitation demonstration going, our global cap, but we are carefully moving forward because we think there's a lot of bloat in the system that still needs to come out before we really want to lock in. And I do think that really we're going to tier. You know, we will always have a stratified basket. We will not move to the state to a full kind of capitated model. We'll have different levels, and you have to when you have rural frontier areas. And we don't have the same standardization across the state. We don't have dominant players statewide, so we know we've got to have, again, some unique strategies. But I absolutely think you'll see a much greater movement into capitation, especially as more and more of the systems integrate. So, you know, as we see more of the primary care practices being owned by large integrated systems and whatnot, we are in discussions about when will be the right time, and that'll come with this maturation.
In that bloat in the system, Bill Dombey mentioned that this morning, you know, the continued ratcheting down in the reimbursement rates and still high margins. So, you know, that bloat is obviously still believed to be there.
Well, look at the
I'm not sure, I'm
price
just the messenger.
and quality variation. Until we can really see this standardization, really understand why we have this extraordinary discrepancy.
So Marguerite, what are payers going to do related to ICD-10? How are they going to ensure that payments aren't held up with this ICD-10 conversion in the fall?
Boy, we do have people very concerned about that. So I think they're going to complain a lot. They're going to come forth and demand to get answers and payments. You know, there's just a lot of uncertainty out there. But it's, you know, they've gone through that before, and I think because they've waited so long for this to happen, I'm just not sure. But I know there'll be a lot of hand wringing and gnashing of teeth.
So are you saying payers aren't doing anything to ensure that payments aren't held up?
No, you know, they've got rules around speedy payment, and they have to adhere to those. Those are, you know, they can't delay payments beyond 30 days. Not 30 days. There's it's 120 days. Yeah, for clean claims. So, you know, there are statutory regulations that don't allow, you know, that kind of thing to happen. So, you know, it's just, but the ICD-10 is the new coding manual, right? So isn't that what you're talking about?
Yes.
Yeah, so, you know, we're also working on Clean Claims Task Force in Colorado. We're one of the only states to actually be doing that. We're probably going to be the model for the rest of the country. And so that's ongoing right now. Sue has just turned it over to the Division of Insurance. Thank you, Sue. And so,
it's all yours.
So, you know, again, we don't get in the middle of contracts between providers and carriers. That really is not our purview. We are there to regulate the filings, and so payments really will fall into another bucket.
Well, let me ask, you know, maybe more directly to Chris and to Susan, maybe your Anthem hat on and your hat on at Cigna. What are you doing to ensure that
we're ready for ICD-10, and I would think most of the major carriers are going to be ready for it. I think the real question is the audience ready for ICD-10, and if because systems coded, you're billing people ready for it, because we spent a gajillion dollars on getting it put up and running, so we're ready. And I will imagine United and any others are as well. I can't imagine any of them haven't spent the same amount of money, although I don't know. And I could always hope one of them would screw up. But we're ready. But we're ready. I think the issue is going to be there's a lot of the delivery system that didn't invest in the infrastructure and waited till the last minute, and that's really where the challenge is going to be, is actually submitting it on an ICD-10. And we've been out educating. We do it doing a lot of our, and I know a lot of my competitors are out doing the same thing, but I think that's really where the hitch is going to be.
So if I'm a provider right now and I'm not prepared yet, what should I do? What should I be doing right now? What are some of the options?
There's all sorts of vendors out here, and find them.
Yeah, I mean, that's really the key thing. It isn't something to be undertaken without appropriate support. Even within the health plans, the complexity for us to do it was pretty significant, and we didn't try to do it without assistance. I don't know about you guys, but we had lots of help. I think anyone who's maybe placing bets on this. If there's going to be another delay, my thought is it would be during the sustainable growth rate negotiation, again, that's going to come up because the physicians are scheduled for our annual 24% pay cut that keeps getting put off. Maybe it's 26 now. And there are those on the provider side that are asking for another delay, but I'm not hearing a lot about it. I don't know if you guys, I wouldn't be in the group betting against it at this point. Last year, maybe, but I don't think I would going forward. I would go out and find someone to help.
So we have just a little over 5 minutes left. So let's start with you, Sue, right here. What's your crystal ball on any other rules or regulations that might change in the next maybe 16 to 18 months related to payment?
Well, obviously all this integration has been a key theme, and I think really getting aligned with partners, creating joint operating agreements, reaching into these new care coordinated environments is going to be just so critically important to get on right away, and I venture most people in this room are already moving down that path. I do think that there'll be more harmonization with our private partners. Public and private aligned. I think you will see many, many states come forward. A lot of states can't avoid the expansion opportunity under ACA. And so you're going to continue to just have huge numbers of folks that present that are going to need services. I also think there's going to be a pretty significant movement about workforce. I know our governor, who's the chair of the NGA, has a workforce initiative going on, and I think we're going to start seeing a lot of the scopes open up and get people practicing to the top of their scopes, because we just aren't going to be able to handle this load in this country. California's got a virtual dental home project that's really exciting. We're looking in Colorado at replicating that type of work. We're also really trying to push with our mid-levels, our nurse practitioners. Loved the session about some of the emergency room kind of ways we can get those unnecessary. Oh, sorry about that. It's that emergency room thing. So I just think that you're going to continue to see a lot more rationalization from the front-runner states, and I think there's all sorts of folks aligning to evaluate and measure, and I think this value proposition, it's going to be pretty easy to deliver on. When you look, for example, of our third year in the accountable care framework in Colorado, delivered over $100 million in gross savings. So I really think that there's no turning back. This is not like the old days because the industry is really pushing for this reform. So again, for those of you saying it's not going to happen, we've lived through this before, you're wrong.
Yeah, so I would echo that. I think you got a really great opportunity, and that's exactly it. It's an opportunity. I think where there's been a lot of status quo and inertia in the different parts of the value chain, I would say that is not the case right now. It's in flux. I think we're experimenting. I think my competitors are experimenting. I think the states are experimenting. And if your strategy is, I don't know, you're speaking to any one of you, but if your strategy is, hey, this is the way we've done it, and we're going to continue to look through this to figure out a way how we can continue doing what we're doing in order to get that going forward, that is probably a dead-end strategy. You really should step back and think about where you see the market in flux and figure out how you're going to add value in a different part of the value chain or in adjusting that value chain. If you're not thinking that, then I would suggest your strategy is relatively short-sighted.
Marguerite?
Thank you. To put this into perspective, in 2014, Medicare fee-for-service payments were $362 billion, but HHS has already seen promising health results and cost savings with alternative payment models due to existing ACA programs of $417 million. Now, that doesn't seem maybe like a lot compared to the billions, but you can see that the trend is going that way. And, as we continue to I guess, mature the ACA model, we're looking at what's going to happen next with essential health benefits. And I would really encourage you to try to get your data in line, just like Susan said. Make your case, because as you go to carriers, you go to your different payer sources, you've got to show how effective your services are. And that's what we're seeing. I'm getting visits every day from ophthalmologists and physical therapists, and eating disorder groups. It's sort of, right now we need everybody at the table. It can't just be physicians and hospitals. It's got to be all types of providers to take care of the people who now are seeking health care in broader ways than we've ever seen before. And they've got coverage. So that's really the good news as we move forward. And I really sincerely believe that you play a huge role.
Susan.
I think it comes down to the statement, know thyself. Know who you are. Know who you're serving now. I'm going to predict, I'm currently with a company that's working in risk-adjusted bundles, which has been rather fascinating because it's a combination between population health and cost-effective care management. And you're going to need to understand who you serve that will benefit the most from your high-intensity services. Just as we've talked about practicing at the top of your license or expanding scope, not everyone is going to need the exact same model. So your ability to develop flexible models that enable you to manage cost, to collaborate with new partners on a much different model, even as Chris mentioned, data back into the acute care system is going to be critical for success. So understanding yourself as well as the community that you serve is something that you all can do and are doing already. And in some cases, you know better than any of us. You've been there. You've been to the home. Tom Scully, when he was the head of CMS, when we used to go to him with a problem about a community, he'd say, "Have you been there yet?" That was his favorite line. And he would send you out to find out what was happening. So please invite people into your world to understand what you bring into this new model of continuous care or life cycle, because without you, I don't believe we're going to succeed. It really is critical that as we move people into the home setting and provide services in that setting, you're the safety net that's going to help us understand how best to do that. So look forward to watching this part of the industry really take a leadership role in defining the new payment models.
Well, great. Well, thanks to all of you. There were a lot of takeaways, a lot of information shared. We really appreciate you being here. And so let's give this panel a big round of applause. Thank you.
Thanks so much, everyone. Recreation begins in about 15 minutes for all of you who are recreating today. Thank you.